Yes, this is Kim Youngjae, Director of Korea Dental Hospital. Building on our previous session, today I will be discussing the law of maximum and minimum in occlusion. It is called the minima and maxima law, or the minimum-maximum law. I believe that the law of minima and maxima can be difficult to understand because it is a mathematical concept. When explaining occlusion, it was difficult to explain using conventional methods, so I began using mathematical explanations. I understand that there have been about 2 Nobel Prizes related to the law of minima and maxima. The first prize was awarded to the protagonist in the movie A Beautiful Mind. The protagonist of that movie received the Nobel Prize in mathematics related to the maximum-minimum principles. Since then, it has significantly helped solve mathematical problems without definitive answers in modern times since the 50s. Additionally, a few years ago, someone received the Nobel Prize in economics by mathematically interpreting behavioral patterns that influence consumer decisions using these maximum-minimum principles. The idea is that because everyone wants to buy good products at low prices, they make decisions to minimize their risk and maximize their gains. Therefore, someone received the Nobel Prize in economics by introducing mathematical concepts into these behavioral patterns. To give a recent example, there is the movie Rebel Without a Cause, starring James Dean. At that time, there were races where drivers would drive recklessly with cars charging from both sides. There are cases where both proceed straight and collide, cases where both avoid each other, and cases where one avoids but still ends up in a collision. We compete based on these 4 possible scenarios. First, those who avoid are referred to as cowards, and it's sometimes called the coward game. This is a movie about an era when people played such life-risking games. It's called a chicken head. People who play such foolish games are looked down upon and referred to as such, so this game is also known as the chicken game. This is a commonly occurring situation, and you can see such cases in real life as well. There are many distribution companies in the world. There are many companies like Company E. In the past, there was Carrefour, and now purchases are made online via the internet. Such distribution companies always claim to sell at the lowest prices. All distribution companies claim their own products are the lowest priced. If every company engages in price undercutting, sales might eventually increase, but mutual profits would decline, potentially leading to companies going out of business. However, given the industry's nature of exclusive distribution, selling at the lowest price may be the appropriate strategy for department stores, distributors, or online sales. Some clinic directors have adopted this price competition, marketing their dental practice as the cheapest. But competing in this manner could result in only those clinics surviving while all surrounding dental practices fail. I believe that should not happen. Recently, 2 dental clinics advocating the lowest prices have opened near our clinic, and I am curious to see the outcome. I wonder whether our clinic will go out of business or if their profits will be minimized, making their practices struggle. Even if advertised as the lowest price, I think that for bone grafts and various surgeries, the cost won't be set as low as promoted. They refer to such expressions as the max-min principle. This concept can be applied to implant occlusion. When performing implants and prosthetic restorations, whether or not to allow contact is important. If contact is allowed, the implant's fixture or abutment will be at maximum risk, and because the natural teeth's occlusion is low, the natural teeth will gain maximum benefit. Conversely, if the natural teeth contact first, and the implant does not, I believe the implant will be safe until the natural teeth are lost. So ultimately it becomes a dilemma. It's also known as a zero-sum game. Therefore, it's often referred to as a dilemma game. There is something called the prisoner's dilemma. For example, there are 2 accomplices, A and B. If a situation arises where these 2 individuals are interrogated in separate rooms, they are each told the same thing. If you do not confess, both will serve 6 months in prison. If both confess, both will serve 5 years in prison. If you confess, I will let you go and have the other person serve a 10-year sentence. If discussions proceed in this manner, it ultimately leads to both parties admitting guilt. This occurs because they approach the opposing party's defendant and communicate in the same way, without considering the potential outcomes for the other party, and by solely aiming to maximize their own benefits. When confronting such scenarios, they opt to confess instead of cooperating. Ultimately, because both are making decisions to maximize their own gains and minimize risks, in criminal psychology, The occurrence of both parties ending up in prison is explained using the law of maximum and minimum. Therefore, there are quite a number of similar examples. There are many, and in some respects it's unfortunate. Sometimes unavoidable situations arise. When treating implants, there are various factors to consider. Whenever possible, we must evaluate which option is more advantageous and which choice is safer. I am deeply contemplating how to better assist patients. We must find methods that are safe for me and beneficial for the patients. Finding such methods is not easy, but these factors must be considered when making treatment decisions. Therefore, today I will explain how I make decisions in various situations. Min-max theory. It is also known as max-min or min-max theory. Making judgments is quite difficult. Regarding this, I will first cover the general overview, and then explain the min-max theory in more detail, which I believe will make it easier to understand. To provide a general overview, the total occlusal support must be greater than the overall occlusal load. The significance of implant treatment is that even in situations where many teeth have been lost due to periodontal disease, patients do not experience a decrease in food intake. I have rarely seen patients reduce their food intake. Except in cases where they cannot eat due to pain, patients swallow food regardless of missing teeth. From the patient's standpoint, they need to eat to survive, so even if they can't chew, they consume food, and if they have teeth, they chew and swallow the food. There is an occlusal load required for mastication. Whether natural teeth or implants, the occlusal support must be equal to or greater than the necessary occlusal load for the patient to effectively perform mastication. Therefore, for this reason, I place as many implants as possible. It is sometimes recommended to place one implant for each missing tooth. Natural teeth have a large root surface area. They are wide. Due to the large root surface area, treatment plans are designed to use the widest possible fixtures to restore the occlusal support for the lost tooth. Furthermore, ultimately, the most important factor is placing the implants in optimal positions and orientations. Good positioning and proper angulation do not refer to implant placement perpendicular to the horizontal plane, but rather vertical to the occlusal plane. I don't think this is well understood. They do not fully grasp that implants must be placed vertically to the occlusal plane. There are Spee's curve and Wilson's curve on the occlusal surfaces. Implants must be placed with these considerations in mind. For example, regarding Wilson's curve, in the maxilla, the fixture is placed with a slight buccal inclination. In the mandible, fixtures are placed with a lingual inclination, and in the maxilla, fixtures are positioned with a buccal slope to allow the prosthetic crowns to have an occlusal inclination. In the mandible, fixtures are placed with a lingual slope to enable the crowns to have an occlusal inclination. In the mandible, fixtures are placed with a mesial inclination. In the maxilla, fixtures in the anterior region are placed with a labial inclination. First and second molars typically have a crown distal inclination, but for convenience, they are sometimes placed with a mesial inclination. Except for the maxillary molar region, it is generally common to place implant fixtures vertically on the occlusal surfaces. And the second consideration is the biodynamics of implant occlusion. After placing the implants, prosthetic restorations are performed. In the initial stage of prosthetic restoration, the patient's occlusal force does not increase. Since there has been a period of tooth loss, the masticatory muscles are also greatly weakened. In the early stages of implant prosthetic treatment, occlusal force does not suddenly increase. When implant prostheses are placed in the oral cavity, an adaptation period is needed. Therefore, excessive occlusal force cannot be applied. Therefore, masticatory efficiency decreases. After a certain period of time, masticatory habits adjust to the shape of the new prosthesis. Additionally, as the muscle tone required for chewing increases, masticatory force or occlusal load increases. Therefore, the success or failure of implant treatment seems to be determined within a week after placing a new implant prosthesis. If the implant is going to fail, it does so during that period, and if there are no problems, it can last up to a year. After 1 year, apart from issues such as crestal bone loss, it seems to be fine. Connection. Depending on the type of abutment connection or the depth of implantation, the duration for which the implant is maintained varies. Whether it lasts 5 years, or 10, 20, or even 30 years is determined. Therefore, reducing the width of the implant's occlusal surface is also important from a biodynamics perspective. If you place a large restoration, the occlusal forces increase. During this process, some patients may report that the prosthesis of their newly placed implant does not function properly when chewing. They tend to be sensitive patients. Therefore, I will provide a straightforward explanation of biodynamics. Up to 1 year after implant placement, the rate of osseointegration increases. They call it osseointegration, although that's not the exact term. The osseointegration rate is approximately 50% immediately after the second surgery and prosthesis placement, and it can reach up to 100% within the following year. If overload occurs during this time, the risk of implant failure increases, so it's best to use them cautiously for approximately a year. I explained that even if the prosthesis doesn't function perfectly, this approach is actually safer. Some patients understand this, while others demand that it bite optimally regardless. Some people mistakenly believe that implant therapy is exceptional and that once implants are placed and prostheses are fitted, there are no dietary restrictions and the occlusal force becomes very strong. It seems that it was difficult to explain biodynamics to these patients. Let's examine the general factors related to stability. Occlusion is highly related to the longevity of implants. It's important how long the implant lasts and how well it functions in chewing. That is, how efficiently it can restore masticatory function. Some people misinterpret the concept of balance between centric and eccentric movements. There is discussion about whether balanced occlusion refers to canine guidance, group function, bilateral balanced, unilateral balanced, or fully balanced, but it is a broader, more overarching concept. It means that centric and eccentric are balanced. It's total occlusion. In any method, if the existing natural teeth are worn down, group function occurs. If significant tooth wear occurs and excursive tooth contacts develop up to the molars, it can be treated with unilateral, bilateral, or fully balanced occlusion. It is important to align well with the existing condition, and sequential guidance was discussed previously. You must adjust the occlusion to allow for sequential excursive tooth contacts. Thirdly, it must harmonize with the existing occlusal condition. Malocclusion ultimately requires restoration in the form of malocclusion. This is a natural occlusion. Therefore, in the past, this was referred to as physiologic occlusion in Europe. Because you can't suddenly change a patient with Engel's classification class 3 to class 1 overnight. You should not restore prosthetics to class 1 when the patient's occlusion is in class 3. Logically, you cannot restore prosthetics to class 2 when the patient's occlusion is class 3, or to class 3 when the occlusion is class 2. Considering harmony with the existing occlusal condition, malocclusion should be restored as malocclusion. If the natural occlusion is good, prosthetics should be done to match that state. Understanding this concept can be somewhat difficult. This is because most only learn about ideal prosthetic forms. They were taught that this is the ideal occlusion, but when asked why it should be implemented that way, there is no particular reason. However, knowing it is impossible, it is incomprehensible to proceed this way just because it was taught. We need to inform them that it is impossible. Ideal occlusion is all about canine guidance. In the past, occlusion was managed in that manner. They ground down all the natural teeth so that only the canines would contact, calling it canine guidance. However, this ultimately led to occlusal diseases, causing difficulties for many patients and dentists. I believe that malocclusions should be treated as malocclusions. It is the natural, reasonable logic. But because those who teach occlusion emphasize ideal conditions so much, most dentists get confused at that point. So I think there were many misunderstandings. Next, we consider the distribution of occlusal forces similar to those of the lost natural teeth. This relates to what was discussed earlier. The position and angle of the implant should resemble that of natural teeth, and if possible, a fixture size that can restore the amount of occlusal support provided by the lost natural teeth should be used. Next, I recommend using fixtures that have shapes similar to those of the natural teeth. I consider this to be the case. Therefore, it is essential to thoughtfully consider both natural tooth support and implant support and to design the occlusion strategically. In cases of occlusal collapse, full mouth rehabilitation should be considered. Today, one patient came in with malocclusion. I explained that a full set of implants might be necessary. I suggested performing orthodontic treatment, if possible, to determine the precise implant placement positions. I advised, let's place the implant fixtures in good positions and directions. This patient already had 3 implants placed, but one of them was not in an optimal position. One of the issues with this position is unfavorable, so I suggested removing it and placing the implant in the new location. I explained it as follows. If the malocclusion is severe, I would implant in the same position and direction, restoring the site of the original missing tooth. Ultimately, this would recreate the malocclusion. This would further deteriorate the occlusion. Therefore, I recommended that the patient undergo orthodontic treatment first before implant therapy, leaving the decision up to the patient. If the patient requests to implant as is, I will proceed accordingly. If they decide to undergo orthodontic treatment first and then receive implants, the treatment will be adjusted accordingly. Next, regarding local factors, the same considerations apply. Implant orientation, the influence of load direction, the size of the implant. Furthermore, you should examine the topology, topography, and geometric forms of the implant restorations. Then, you need to consider the condition of the peri-implant tissues. There are hard bones and soft bones, and sometimes cortical bone is present, while other times it is not. Of course, there is cortical bone surrounding the area, but after the implant is placed, if there is no cortical bone anchorage, it often fails during initial occlusal loading. Therefore, using a fixture that is too small results in the fixture being plunged deep into the cancellous bone. Consequently, implants may fail during initial occlusal loading, and osseointegration can be compromised, leading to many failures, so further research is needed. Thus, it presents a dilemma. Ultimately, it involves anterior guidance and posterior disclusion. Whether it is canine guidance, group function, unilateral balance, bilateral balance, or fully balanced occlusion. This means that one side contacts while the other side disengages. The minimum-maximum rule is prominently demonstrated in eccentric movements. In the end, areas that are frequently contacted and come into contact first will experience increased occlusal forces and loads, while areas that become disoccluded remain free from occlusal load, making them actually safe. Therefore, understanding this is quite difficult. This is very challenging. We refer to it as fully balanced occlusion when both anterior guidance and posterior guidance are established. When such patients visit me, I allow eccentric occlusal contacts to be separated. This prolongs the longevity. However, because the eccentric occlusal forces that the implant must bear are transferred to the adjacent teeth become endangered. Thus, the implant I place becomes safe, while the adjacent teeth become at risk. Furthermore, concerning posterior disclusion, in canine guidance, anterior guidance is established, and the molars become disoccluded. That's also good. Because if I had placed a posterior implant in canine guidance, it would have been beneficial. However, conversely, if I had placed an anterior implant, I would be exposed to maximum risk. If implants are placed in the anterior region of a space-maintained patient, this means that lateral occlusal forces increase the most. In that case, the implant I placed would be subjected to maximum risk. In my opinion, that seems disadvantageous. In cases of open bite, anterior disclusion occurs and posterior guidance is established. If posterior guidance is present, posterior implants are actually at risk, and anterior implants will not fail. Initially, there is primary stability, followed by second surgery, and once implant prosthetic restoration is completed, it is free from occlusal forces, making anterior implants the safest treatment option, so we can confidently assure patients that anterior implant treatments will be maintained without worry until their posterior teeth are lost. Saying that both anterior and posterior teeth are lost means that there is no occlusion. This is pathologic occlusion. Such cases are rare. However, there are cases where only one tooth makes contact and the rest do not. There are cases where only a few teeth make contact, and there are also cases with multiple missing teeth. If all opposing teeth are missing, it results in posterior disclusion and anterior disclusion as well. In some situations, it is safe, and in others, it is disadvantageous. Most dentists learn in a very simplistic manner. What I mean is that most dentists are taught that canine guidance is safe. Therefore, almost all dentists strive to establish canine guidance. However, anterior implants and canine implants are subject to the highest risk. We do not consider open bites. This is excluded from consideration as it is a form of malocclusion. Fully balanced occlusion? This is difficult to achieve. Since it is challenging to replicate, we treat it as an occlusal model that is not used and excluded entirely. However, there are instances where full dentures are fabricated or elderly patients with natural dentition are treated. There are many patients with fully balanced occlusion when they are elderly and have all their natural teeth. The occlusal patterns present in elderly patients with natural dentition have a high likelihood of fully balanced occlusion. This does not mean that we would refuse to perform implants when these patients lose their teeth. It would be problematic to think that way. We are thinking too simplistically. Only by employing multidimensional thinking can we establish a strategic treatment plan. We must not unconditionally insist on premolar guidance. When looking at patients in their 20s, they rarely visit the dentist except for trauma cases. They don't have much reason to come to the dentist. Patients rarely visit the dental clinic unless they have issues such as caries or tooth loss due to trauma. As they age, they inevitably develop fully balanced occlusion or pathologic occlusion, leading to the destruction of periodontal tissues and tooth loss, necessitating implant treatments and therefore making regular dental visits essential. Therefore, the issues we need to address can be seen as pathologic occlusion and fully balanced occlusion. Otherwise, they are primarily patients with bilateral or unilateral balanced occlusion or group function. However, disregarding the patient's occlusal type and treating only canine guidance as the ideal occlusion implies that patients beyond canine guidance are not being seen, which is unfortunate. Therefore, when considering and comparing canine guidance, group function, bilateral balanced occlusion or open bite, the anterior guidance and disclusion differ from each other. As shown in the table, canine guidance is labeled as anterior guidance 1. I wasn't sure how to express it, so I used these numbers. Group function, the incisors also contact and the molars disclude. And bilateral balanced occlusion has less occlusal load on the incisors and the molars do not disclude. In this way, I have expressed that in an open bite, the incisors all disengage and the molars contact. This is the opposite situation. We should assess the situation in this manner. Dentists may encounter cases where there are risks or safety depending on which tooth they are restoring with an implant. Although it's not an exact scale, it numerically represents how one should formulate a survival strategy in such a dilemma. At this level, the risk of incisor implants is considered high. And in canine guidance or open bite, molar implants are associated with this level of risk. This is how I have expressed it. I hope you consider this table. So I created a table. And I will discuss it further after reviewing it. This was an older chart, so I have updated it. Therefore, this is an older chart, and if you look at it this way, let's skip the content and start with the table. Upon reflection, it ultimately presents a dilemma. This is a dilemma game. This indicates an increase in occlusal contact, and while bruxism patients experience increased occlusal load, their occlusal support is good. Most bruxism patients do not have missing teeth. They present with tooth wear, but often have all their natural teeth. Bruxism patients also seem to have little to no periodontal disease. Therefore, bruxism patients have increased occlusal support. When occlusal load increases, there is ultimately a higher incidence of periodontal disease due to masticatory force. A heavy bite ultimately increases both masticatory time and efficiency. Since both TMD symptoms decrease, please consider this. It would be beneficial to research masticatory dysfunction, periodontal disease, light bite, TMD, and MPDS. Whether the patient's masticatory force has increased or occlusal support has significantly decreased. There are also such statements. It is said that periodontal disease and TMD do not occur simultaneously. Almost all TMD patients have teeth. There are many cases where teeth are present along with bruxism or a heavy bite. Next, there are many patients with malocclusion. Especially, there are many Class 2 patients. Class 2 malocclusion is the most common. Considering this, I speculate that occlusal problems manifest in the teeth and are transmitted towards TMD. If periodontal disease is present, teeth may be lost or become mobile. We recognize that such occlusal issues are addressed within the teeth or periodontal tissues. If we carefully consider these factors, I believe we can gain insight into various aspects. I would like to discuss this diagram. In creating the chart, it was not possible to make it three-dimensional. I contemplated it extensively, but it was challenging. Therefore, I depicted the three-dimensional aspect by overlapping two two-dimensional diagrams, sharing one dimension. So, if we categorize into central incisors, lateral incisors, canines, first premolars, second premolars, first molars, and second molars, in normal occlusion, In the case of incisors and premolars, horizontal occlusal load is highest on the incisors and decreases towards the molars. Vertical occlusal load increases towards the molars. During centric occlusion, the incisors were elevated and only the molars made contact. This is expressed that way because the contact area of the molars is large. For this reason, I consider the point where the horizontal occlusal load of the incisors and the vertical occlusal load of the molars intersect as the balance point of masticatory forces. I am not certain about masticatory efficiency. It could increase or decrease, showing variability. If you look at the second illustration, on the right, the vertical occlusal load increases. Vertical occlusal load increases towards the molars and decreases towards the incisors. Thus, combining these two illustrations, the horizontal occlusal load increases towards the incisors and the vertical occlusal load increases towards the molars. To put it simply, that's the case. So when placing an implant, consider this chart. In the case of a premolar implant, if it extends beyond the blue line, the restoration I placed on the implant will contact first. If the restoration is done within the blue line on the inner side, the natural tooth will contact first, preventing contact with my implant. The same applies to molar implants. More than concepts like centric or eccentric positions, it's about vertical occlusal load. So when there is a unilateral bite, if it goes below the green line, occlusal contact is reduced. Moving above the green line causes the implant restoration to contact first. This leads to early contact and traumatic occlusion. The reason for using this table is to explain whether anterior guidance results in contact with the premolars. There are also questions about whether the incisors make contact in the centric position. Because a single definitive answer regarding contact could not be determined, it is illustrated graphically. As shown in this graph, patients with TMD, MPDS or periodontal disease exhibit decreased occlusal force. Implant treatments are very safe. In any case, placing prosthetics within this area is safe. Since this is the eccentric position, this side represents the central position. If eccentric tooth contacts are placed inside the gray area, they can be considered stable. Passing through the equilibrium point is considered normal. If the occlusal load of patients with bruxism or clenching increases, it will eventually exceed this line. These areas will exceed. Then it can lead to occlusal breakdown or collapse. Therefore, I explained it in this manner. Exceeding the limits of occlusal support increases my level of risk. I am continuing straight. Remember the coward game earlier. Anyway, I'm not avoiding it and moving forward. By reducing occlusal contacts within the limits of occlusal support, the implants I have placed will avoid occlusal loading, allowing the natural teeth to bear the structure. Considering these factors will help you better understand the min-max principle. Using such examples to explain, it seems this information was conveyed more effectively. If prosthetic restoration is possible only within P1 or P2, there will be no problem. The closer to the green line, the higher the likelihood of periodontal tissue destruction and implant failure. However, using implants with larger surface areas, or selecting an implant design with a strong abutment connection structure so that the implant can endure. If the patient's bone condition is good, they could withstand even exceeding the limit line. Then, rather, we might employ a strategy that increases the occlusal support or contact of the implant to protect the natural teeth. This approach may put the implant at risk. However, in any case, strategies are sometimes deliberately used to protect the natural teeth. If the support of the natural teeth is too weak and there is no force, or if there is significant mobility due to periodontal disease, the implant will end up contacting first no matter what. In such limiting situations, a decision must be made. In any case, I believe problems occur when the occlusal load exceeds the limit here. Therefore, within these guidelines, you must clearly decide which type of implant to use, determine whether it involves eccentric or centric occlusion, and appropriately adjust the occlusal contacts. Looking at it here, it's a straightforward matter. As you move anteriorly, anterior guidance increases, and as you move posteriorly, eccentric occlusal contacts decrease. Then, moving towards the posterior, centric occlusal contacts increase, and as you move anteriorly, centric occlusal contacts decrease. Other than this, there is nothing particular. Furthermore, you need to understand how much the patient's inherent occlusal force has increased and the extent of any pathological state. If the patient has TMD, you should not apply occlusal forces. Many of my patients fall into this category. Especially among female patients, there are those with particularly small physiques. Additionally, there are patients in poor health and lacking strength. These individuals can successfully retain medium or slightly smaller sized implants. Even when teeth and implants contact simultaneously, they retain well. However, the situation is different for patients who are very large in build or have a lot of muscle. Among the patients who came in today, there was someone who was twice my size. He was very tall and had a large physique. He received multiple implants, and patients with such a large build cannot endure if they cannot eat. Almost all such individuals opt for implants because they cannot sustain their lives without being able to eat. Patients of that larger stature cannot maintain their lives by skipping meals. It would be abnormal to starve. I explained to the patient that we implant fixtures of the largest possible size. For that patient, we placed 2 implants in the upper molar region, each with a diameter of 7.0 millimeter and a length of 11 millimeter. All 3 implants were placed immediately after extraction, and in mandibular molar number 7, we placed an implant with a diameter of 8 millimeter and a length of 9 millimeter. Because we implanted such large fixtures, they could be compared to the implants on the opposite side, and the patient was extremely pleased. However, implanting such large fixtures presents strategic issues. The patient's occlusal force has significantly increased. An increase in occlusal force is not a problem, but the increased occlusal load must be properly managed. What should we do to compensate for this? There is no choice but to increase occlusal support. How to increase that occlusal support was an important issue for me. Therefore, it seems appropriate to analyze patients using such charts and place implants accordingly. You must develop a sound strategy regarding the occlusal forces of the incisors and molars. Let us also review this chart. Moving into the red indicates a risk, but it allows for the protection of natural teeth and fosters a mutually supportive direction. Even if it reaches the yellow zone, patients do not complain about not being able to chew. It should not pose a significant problem. When it reaches the blue zone, patients will visit with complaints of inability to chew. The blue zone is the safest area. You must carefully choose the direction to take. As you can see, canine guidance follows this pattern, causing the incisors to contact more and the molars to contact less. Next, we concluded that the group function is oriented in this direction and bilateral balanced occlusion is at this level. Please carefully study the research by looking at this graph. This is the balance point. And as we move forward, the envelope of closure shifts towards the anterior region. I describe it that way, but I'm not sure of the exact terminology. It's explained that way in mathematics books. As we move backward, the envelope of closure shifts towards the posterior region. Therefore, it's essential to carefully determine where to place the implant. The extent of the patient's existing anterior eccentric occlusal contacts and the degree of centric occlusal contacts to ensure appropriate occlusal contact occurs. It may cause occlusal contacts to be stronger and more forcefully engaged than natural teeth, or the implant restoration may have lower occlusal contact areas that do not reach, resulting in reduced occlusal contact compared to natural teeth. It can be done similarly. We must develop a strategy that is mutually beneficial. Some patients also recognize this. After placing implants, the natural teeth become too loose, so he becomes aware that his natural and neighboring teeth are becoming mobile. If only the opposing teeth are mobile, there is no issue. However, the adjacent teeth should participate in occlusal support and provide this reinforcement. If they are weak, it becomes problematic. There are patients who understand that implants may fail due to weak occlusal support from natural teeth. If you offer to perform the procedure once more, they are grateful. They may initially express that their own teeth did not provide sufficient support, resulting in loosening. It's easy to explain to such individuals. Being able to explain and having the patient understand is ideal. The most difficult situation is when an implant fails and the patient cannot understand the explanation. I am unable to explain. In the early stages, I also only placed thin fixtures and could not place thicker ones. Their position and orientation were also suboptimal. I tried to perform prosthetic restorations only with under occlusion. This led to over-occlusion, resulting in traumatic occlusion. When such issues arise, the screws loosen and crestal bone loss occurs, ultimately necessitating removal. I am unable to provide an explanation because I was unaware at that time. Therefore, from the patient's perspective, it is inevitable for them to become upset. They came trusting the doctor, but not only was there a failure, but also no explanation was given, which is understandable. I have encountered many such challenging situations. If you cannot provide an explanation, it becomes a problem. It does not mean that under-occlusion should be mandated unconditionally. Each patient presents with highly diverse occlusions and distinct chewing patterns. Understanding this and achieving occlusal support that is equal to or greater than the required overall occlusal load was my treatment goal. Thinking that natural teeth are always better, or that implant occlusion must always be less occluding than natural teeth. That is not the solution. Ultimately, it leads to the failure of both the patient and myself. You need to select fixtures with a large surface area and design them to withstand excessively concentrated occlusal forces. By doing so, you can provide overall occlusal support that is equal to or greater than the required occlusal load. Because that method was successful, I received recognition from patients. That's why many patients still come today. The implants we place last over 20 years. I think all the patients know. Because in Korea, everyone gets implants, and many people around them also get implants. So they seem to feel a difference compared to their surroundings. When patients with bruxism or clenching come, it's frustrating. If it goes below here, even if it's the red area, patients seem to perceive it as an underbite. They come seeking because they feel it's not chewing well. To bring it up to the red line here, we need to increase the diameter and length of the fixture to enhance occlusal support. I cannot agree with those who say it's possible with implants of up to 5.0 mm diameter and 8.5 mm length. It seems they are thinking very simplistically. If 160 cm height is sufficient, does that mean anything above that is unnecessary? Should I say it's all failures if they are not 180 cm tall? I have no way to express it. It's also regrettable. In other words, it seems like a will not to study anymore. It seems to be the belief that there is no need for further study and that this method can solve everything. That was the impression I received. So it's somewhat amusing, and I apologize. I shouldn't keep laughing, but when I think about it, it's so funny that it's quite regrettable. I'm saddened that renowned instructors in implant education are saying such things. I've studied implants for a long time, and I'm an expert in the field, so it's hard to understand the claim that there's no need to study beyond that. Our implants are being exported to Turkey. A dealer in Turkey is selling German products alongside our products. They claim that the slock implant is complicated to understand, but I don't see what's complicated about it. So I obtained a catalog for a German product and opened it. The German implant they are selling is a one-connection system, and its diameter is only 2.3 mm. Was it 2.4 mm? I believe it was approximately 2.3 mm. If you use a 2.3 mm one-connection fixture for posterior implants, is it possible that it won't break? In the past, a German implant called Ankylos sold well in Korea because it bonded well to the bone. It was easy to place the implants. So many beginners used it. That's why it was widely used in private practices. However, the abutments of these Ankylos implants were expensive and broke frequently, so eventually they stopped being used in Korea. But clinic directors in Turkey say they can trust the product because it is German-made. I don't understand what they mean. They argue that a fixture with a diameter of 5.0 mm and a length of 8.5 mm is sufficient in all cases. It seems they believe that because it's made in Germany, even that thin implant can withstand all occlusal loads. It hurts the pride in Korean products, and it's unfortunate. It's nonsensical, and the product being sold in Turkey is also regrettable. You shouldn't judge in that way, and the same applies to occlusion. The content is difficult, and because there is no one to properly teach, they might think guidance of deciduous dentition is sufficient, but it is absolutely not. These differences in knowledge lead to variations in a dentist's proficiency. It would be beneficial to further contemplate this matter. Examining retrognathism results in increased occlusal loading on the anterior teeth. The molars experience reduced occlusal loading. There is increased molar divergence. Conversely, in cases of prognathism, it appears similar to an open bite, and there are instances of prognathism without anterior guidance. It is similar to an open bite. An edge-to-edge bite occurs when both the anterior and molar teeth contact each other. Similar to fully balanced occlusion, both the anterior and molar teeth make contact. Next, there are patients with reverse anterior guidance. Similarly, in patients with reverse anterior guidance, there is anterior guided molar divergence. The anterior teeth guide in a reverse manner. Instead of the maxilla covering the mandible covers the maxilla, resulting in eccentric guidance. Therefore, in cases of reverse anterior guidance, whether or not there is canine guidance, the situation is similar to anterior guidance. Because it is a malocclusion, the lateral guidance and lateral occlusal forces are not strong. Therefore, as you can see, depending on the position of the implant I place, I need to analyze it and thoroughly assess the occlusal load in the anterior and posterior regions. Next, I need to understand the concepts of anterior guided posterior occlusion and posterior guided anterior occlusion. Examine whether the implant in the area I'm working on has resulted in increased tooth contact compared to natural teeth, whether off-axis tooth contact has occurred, or if cuspid interference has taken place. Similarly, during centric occlusion, determine whether tooth contact has occurred or if cuspid interference has taken place. Then decide whether to have the implant occlusal contact engage or disengage, and assess whether to increase or decrease the occlusal contact. Thinking that the occurrence of occlusal load depends on the contact area, so ultimately it either touches or does not touch, is a binary logic. You need to strategically evaluate the degree of contact. If you want to increase contact, you should choose fixtures with larger diameters and lengths to increase the surface area of the fixture. If we allow for slightly less contact, there is no concern about increasing the fixture size. In the anterior region, significant lateral forces are exerted. When anterior guidance occurs, the length of the fixture is more important than its diameter. In the posterior region, vertical pressure is greatly applied and horizontal pressure may slightly decrease, so ultimately the diameter is more important than the length. However, in cases where both horizontal and vertical contacts occur in the posterior region, both the diameter and length of the fixture are important. When implant treatment fails, you need to determine whether it was because you couldn't secure the fixture diameter or because the fixture length was insufficient, and respond accordingly. Appropriate measures must be taken to resolve the issue. However, you shouldn't misunderstand the issue by attributing it to the fixture's surface treatment or give up, thinking it's unknowable. Someone said that using a fixture with a diameter of 5.0 mm and a length of 8.5 mm is sufficient. Some people only embed the fixture 4.0 mm into the bone and create a smooth surface on top. Nowadays, because mandibular molar implants are challenging, they sometimes do it that way. In such cases, you have no choice but to dramatically reduce the occlusal area and subsequently prevent lateral tooth contact. However, ultimately, attempting natural-shaped prosthetic restoration increases the likelihood of failure. Upon hearing such things, you might think, they said it would surely work, so why isn't it working for me? Naturally, without securing occlusal support, you ultimately have no choice but to reduce the occlusal contact of the implant restoration. Because they are unable to comprehend such matters, they said it would work for him, so why isn't it working for me? This is the only way you can think. Occlusal patterns, implant positions, conditions of occlusal load, whether it's horizontal or vertical, you need to assess these various factors comprehensively. If the dentist cannot make a judgment, no one else can. If a decision can't be made, what ultimately happens? Eventually, you end up calling the dental laboratory and asking the technician to handle it properly. I'm not exactly sure what handle it properly means, but that's how it ends up. Many unfortunate situations arise from uncertain judgments, ultimately leaving success to chance. If you fail, you can try again. However, not knowing where the problem occurred means that even if you try again, you don't understand what needs to be done, leading to repeated failures and losing patients. When patients leave, it hurts your self-esteem as a physician and worsens your financial situation. Confidence decreases, and the cycle of becoming depressed is difficult to endure over time. When you find it hard to withstand the situation and feel there is no breakthrough, the sense of depression persists. Among acquaintances, it seems that many feel depressed due to losing patients. It's not just one or two, there are many. It's regrettable. They say they are studying more, but most of the time they only study simple things like bone grafts or digital dentistry. In the end, without a solid foundation anxiety and instability increase as you advance. Therefore, it's somewhat unfortunate. Please think about this a bit more deeply, and I will skip the other parts as there is a lot written. Next time I have the opportunity, I will conduct further research and explain. Lastly, I will conclude by presenting a patient's clinical case. This is a simple case. There are simply no molars. In the anterior region, traumaform occlusion, TFO, has developed, and the molars are affected in this manner. As you can see, these teeth have no mobility. When I inform the patient that placing an implant here would be beneficial, they decline. Therefore, I explain it this way. Since there are no opposing teeth, there is no occlusal load, and because there is no movement, it only feels normal. To achieve proper occlusion, perform endodontic treatment, and after placing a crown, if it withstands the resultant occlusal forces well, continue using it. If not, an implant should be placed. By explaining it this way, the patient understands. Because there are no molars, there is no centric occlusion. The red area on the premolar represents the centric tooth contact. Additionally, the anterior teeth are not supposed to contact, but due to the lack of vertical support in the molar region, they ended up touching, and the anterior teeth are adversely affected because of TFO. The situation has developed in this way. Next, this side's opposing tooth is a crown. Due to the loss of molars, the vertical dimension collapsed, and as the mandible retruded posteriorly, reverse Wilson's curve was formed in the process of the holding cusps of the upper premolars completely failing. This side does not contact, so it represents the normal Wilson's curve, and this side is the reverse Wilson's curve. And on the contacting side, abfractions occurred, causing these issues. In other words, the teeth that are avoiding contact are safely supporting, while the teeth that are in occlusion are conversely exposed to maximum risk. After understanding the content, these things become apparent. If you look to the other side, this side is still holding up. Therefore, overbite and overjet have also increased. Because when mandibular movements surpass the canines, the upper and lower anterior teeth should achieve an edge-to-edge bite, but since the jaw has moved posteriorly, when eccentric anterior guidance, sequential guidance, surpass the canines, the upper and lower premolars should achieve an edge-to-edge bite, and if further mandibular lateral movements occur, the median premolars should also engage in an edge-to-edge bite. However, this is not currently happening. Furthermore, since the TMJ is no longer functioning, we are unable to achieve an edge-to-edge bite with the median premolars. Upon examining protrusion, the molars are significantly elevated due to the protrusion of the mandible. Therefore, this is likely caused by the extrusion of the anterior teeth. I am not sure where the prosthetic treatment was performed, but the anterior teeth are considerably longer than the canine teeth. As a result, the situation is worsening. In such a scenario, the anterior teeth become highly vulnerable. This can also be explained using min-max theory. Ultimately, a full mouth rehabilitation is necessary to reduce the occlusal load on the anterior teeth. This will prevent the anterior teeth from being lost. In this manner, we create a provisional restoration, prepare a resin shell, perform tooth preparation, and subsequently place implants in the molars. Additionally, implants were placed here as well. This concludes the summary. This tooth is scheduled for extraction. First, we'll remove the crown, and later, by extracting the remaining root, we can perform immediate implantation. So, we have organized it this way. Next, during the provisional restoration, we reduce the overbite in the anterior region and increase the overjet. Thus, the edge-to-edge bite of the premolars and molars is well maintained. But here, the posterior teeth are contacting first, and the anterior teeth have been lost. This has led to TMJ deformation and vertical dimension loss, reducing the interocclusal distance. The temporomandibular joint on this side has been compromised. Therefore, it is evident that the posterior teeth are contacting first. If we grind the premature contact of the molars, the anterior teeth will contact. We need to study this and provide appropriate prosthetic treatment. It would be beneficial to redo the prosthetic restoration on this side as well. It appears that we did this because the tooth was scheduled for extraction. This is the current condition. This tooth is also completely lost. Everything here is in this condition as well. We are trying to manage it in some way. This is also a patient with a new case. Is this called pamperiodontal disease? Or they call it periodontal rarefaction. The alveolar bone has been completely resorbed. This patient was referred and came to see us. He came from far away. All of his teeth were loose, so he probably only chews his food on the implant side. This broke. The implant abutment broke, and the patient was extremely angry. How could the implant break? I explained that it was a natural outcome since he was only chewing on that side. I kept advising the patient to get implants on this side as well, and documented it. If I recall correctly, I discussed it with him about 7 times. However, the patient said he had no means to eat otherwise and wouldn't proceed, so he continued to eat only with this. As you can see, the mandibular angle also appears abnormal here, such as the bone thickness. Also, it seems this side was stronger than the other side. The patient was very angry and there was nothing I could do. These teeth have all avoided occlusal loading. The implants on this side will also last a long time. This is because the occlusal support from the upper teeth is not robust. It feels as if the upper and lower teeth are aggressively pressing against each other. Therefore, these teeth have avoided it. These implants are safe. Both the upper and lower teeth have avoided occlusal loading. The same applies to these teeth. The upper and lower implants have collided. They have indeed collided. Similarly, in this case, one of the two tends to fail. So in the end, this implant failed. It was lost. Should I say it failed? Should I say it was lost? Anyway, this implant failed. From our perspective as dentists, we understand the situation. It's natural that this becomes an issue. However, the patient was angry, asking how the implant could break. He was excessively angry, probably because of the cost. He seemed to want to receive treatment again for free, so I explained it to him repeatedly many times. The patient kept saying he was using it well. I kept telling him that it would break, that problems would arise, and that the bone would resorb. Even after discussing several times before the bone resorption occurred, he kept saying it was okay. In the end, the implant abutment broke like this. The implant abutment is a 3.0 millimeter post, and it broke. Before it broke, you can see periimplantitis around the fixture. So I ultimately had to remove it like this. This is a photo showing the bone attached around the fixture. If you push and remove the bone adhered to the fixture in this manner, everything separates. Therefore, I believe that the concept of osseointegration is not valid. Since the bone tissue closely adheres and regenerates on the implant surface, I think the principle of surface tension is likely at work. Alternatively, it seems to be attached through mechanical retention thanks to the surface treatment achieved by sanding the fixture surface. However, this used a spherical implant made previously, so the RBM surface treatment method was employed. In the case of RBM, the surface treatment is not very effective. Therefore, it seems that RBM surface treatment is likely becoming obsolete. RBM surface treatment easily separates from the bone. However, even if periimplantitis occurs, the fixture surface remains clean, preventing secondary infections from being transmitted, which is an advantage. Therefore, there are those who prefer this approach. In any case, I reimplanted a fixture with a larger diameter. Like this. This enabled it to withstand the increased occlusal load. It's really difficult. If this cannot be explained by the principle of minima and maxima, it cannot be explained logically. Therefore, it is difficult to understand. The rest of the content is similar. As you can see, these are the points we have been continuously explaining. Similarly, if you continue, this applies as well. We must carefully determine how to design the occlusion. This patient was also followed up until recently. I mentioned that it would be beneficial to treat the incisors, but the patient declined. It's not the patient's fault. He was honest with me. He said he could only have his molars treated due to financial issues. So I thought he could live and eat in this condition and treated only his molars. However, he came in saying that his stomach condition was so bad that he couldn't digest at all. He said he returned because the pain was too severe. I asked if that was the case, reassured him not to worry, and told him we would try to treat him as much as possible. As you can see, there is strong anterior guidance. So placing molar implants should last a long time. This is the condition shown in the photo. Fortunately, the airway and related aspects were fine. The jaw wasn't significantly retracted. Of course, it might have retracted, but the head was protruded. Seeing that the cervical spine has straightened like this, It seems that the jaw position moved forward to secure the airway due to a straight neck. Therefore, molar implants were placed and prosthetic restorations were done to match the occluding condition. This patient also aimed to reduce the number of implants. I persuaded him that he shouldn't proceed that way. So I offered a slightly reduced price. Given his difficult circumstances and his severe struggles with gastrointestinal disorders, I recall I lowered the cost a bit. Thus, I provided prosthetics like this, but the issue lies with the eccentric guide rather than the centric position. As you can see, the centric occlusion is in this state. During eccentric mandibular movements, the molars disclude. Therefore, I treated him under the assumption that as long as the anterior teeth aren't compromised, the molar implants wouldn't fail. As you can see, the anterior teeth have been worn on the sides. Normal anterior guidance does not occur. It was a somewhat unfortunate situation, but recently a follow-up was conducted. It's been about 10 years since the case, and he has become much healthier. And surprisingly, this implant has failed. One implant failed, and I remember retreating it. This patient came to my clinic through a referral from a senior dentist at a neighboring practice. I recall they had referred the patient to me because anterior implants have a high failure rate, and they were too apprehensive to proceed. He is an orthodontic patient. As you can see, it seems that the first premolar was roughly extracted. We placed 3 implants in the anterior region, and the patient had a large build. The implants used were small. As you can see, there is not much overbite. Therefore, they naturally last longer. In such cases, the implants do not fail until the premolars are lost. The prosthetic restoration is somewhat extensive and may be unfavorable to occlusal loading, but there is not much anterior overbite. So, if you perform lateral guidance, the anterior teeth will all become mobile. In such cases, this is a safe case for me. Conversely, the premolars are placed in the highest risk situation. Therefore, I advise the patient that if the molars are lost, it could lead to problems even with the anterior teeth, so they should come to the clinic quickly and undergo restorative treatment. The patient immediately understood this advice. So I believe the implants I placed are still being used well. This patient had a somewhat older case, but there was no follow-up. I believe that the implant I performed is in a safe condition and there should be no problems. He is the person who taught me mountain biking several times. Although I had difficulties performing the implant, the results were good, and the treatment was completed without major issues. According to the principle of maximal and minimal forces, if a patient continues to chew predominantly on one side, eventually the teeth on that side will fall out. What happens to the opposing, stronger side, the side with good periodontal support? That tooth is put at the greatest risk. If you continue to chew only on one side and that tooth falls out, you will then chew on the side with relatively better occlusal support. Anyway, because you have to eat, as a result, teeth continue to fall out. From hearing from patients, some have even woken up to find a tooth missing. If occlusion is mismatched, patients seem to continue grinding their teeth or develop some sort of pathologic habit. After discussing this and offering them a meal, they suggested going out for jambon. However, this patient was unable to eat things like shrimp or squid and only consumed noodles and broth. In the end, I remember bringing them in for treatment. It's truly unfortunate, isn't it? There is a process until all teeth fall out. Like a serial killer, teeth are lost in succession. Serial killer. So the occlusion continuously causes teeth to fall out, much like a serial killer. When one tooth becomes loose and falls out, the side with the next best occlusal support becomes the most at risk. When the upper and lower teeth just collide, if one side holds while the other side gives way, it will become loose. Using the principle of maximum and minimum force, we can understand this process. This was also one of the very difficult cases. He only had these remaining teeth. We needed to treat the entire set and align the occlusal plane. I believe we treated it using these two principles and finished it this way. So it became a situation where the anterior teeth do not meet. Instead, the posterior teeth make extensive contact. I don't recall exactly why we did it this way. This implant failed once or twice. The posterior side is the strongest. The post sometimes broke, so we redid it and secured it fully. It's retrusive guidance. This causes a lot of wear. It seems this was continuously under maximum occlusal load. This is it. Only this had some issues and the other side was fine. I think we redid only this implant twice more. There are such cases as well. So here we used a full denture on the upper and what is called all on X on the lower. In all on X, X can be 4, 6, 8 or 10. There are also cases with 12, and some involve placing 14 implants in total. Here, X is 12. This patient was my business partner's uncle and was a practitioner of traditional medicine. I wanted to provide treatment as safely as possible. The patient wanted to distribute implants in the mandible and also place them in the maxilla, 6 in the maxilla and 6 in the mandible. From my perspective, this would pose the greatest risk. So I provided an explanation. I explained that the maxilla could be sufficiently supported with dentures and that maintaining dentures in the mandible would be difficult due to the presence of the tongue. Therefore, I persuaded him that concentrating all implants in the mandible was the appropriate approach. Understanding this, he was treated with a full denture in the maxilla and received a fully bony-anchored prosthesis in the mandible using multi-unit abutments for full mouth rehabilitation. This is how the treatment was performed. It has been nearly 15 years since this treatment was performed. It has been about 15 years. Since he is my business partner's uncle, follow-up is still ongoing. He is still using it well. I heard there are no problems. That business partner has started his own practice, and I still ask him whenever I meet him. Since he is a family member of my business partner, follow-ups are easy, so I always ask him when we meet. I ask if he is using it well and if there are any issues, and he says he is using it well. If you consider it, this was treated most safely under the principle of minimum and maximum. This has no problems 100%. I treated it using this method. However, there was a problem during the treatment process. This patient questioned the dentist on the same floor, asking if this placement was correct. But it seems that dentist told the patient that too many were placed and that if he had treated it, he would have placed 4 in the maxilla and 4 in the mandible to create an overdenture. So the patient came to the clinic and was extremely angry upon hearing that story. He was angry because he felt that too many were placed unnecessarily. If only 4 implants had been placed, the implants would have failed or peri-implantitis would have developed within 5 years, causing significant trouble. However, that patient was closer to a dentist on the same level, so he trusted that person's advice. At that time, there was no concept of placing so many implants. Therefore, the patient had difficulty understanding. If we met today, he might be grateful to me. I am still providing similar treatments in the same manner. People who have placed only 4 implants and performed full mouth rehabilitation, called all on X, or those who placed only 6 implants, are in the greatest danger. They know only themselves. Those who teach only taught in that style because it was more profitable. However, those people do not take responsibility. And when problems arise, they blame you for the treatment you performed. They claim there is nothing wrong with their own teaching. They also say it's due to improper occlusion. There are also many excuses. In the end, only I who performed the treatment am left in the greatest danger. In a way, it's a situation where only the clinic directors who teach that are earning a lot of money. They might truly believe that implanting in that manner is beneficial. They may not want to study further, which could be the reason. Whenever I review such cases, I believe that according to the principle of minima and maxima, I have achieved the maximum benefit, and the patients have also gained maximum functional advantages. He also had a successful treatment and fully adhered to it. The patient also gained maximum benefit and stability. So mutually, both parties obtained good results. We must always look at it from this perspective. Otherwise, it becomes quite problematic. When examining lateral guidance, if it's not a fully balanced occlusion, the upper and lower dentures may become dislodged. As you can see, the anterior teeth make contact, the posterior teeth make contact, and the balancing contacts are also achieved. All anterior, posterior, and balancing contacts have been established. The dentures cannot become dislodged. This is anterior guidance. It is an edge-to-edge bite in the anterior region. Both sides of the posterior teeth make contact. When the lower anterior teeth are completely protruded forward, even when establishing an anterior crossbite, all the posterior teeth provide support, ensuring the denture remains secure. This is the correct approach. Similarly, as shown here, when the mandible moves retrusively, retrusive guidance is created. Nevertheless, it does not dislodge. This is correct. We have no choice but to proceed this way. Failure to do so will result in problems. Here, occlusal capping is performed with metal. If you drill holes into resin teeth, they will break. If you contact the laboratory, they simply provide metal coverage on the occlusal surfaces. Although it may be less aesthetic, longevity is paramount. Therefore, in my case, this seems to be the best approach. Thus, I proceeded in this manner. I will now present the conclusion and conclude the lecture. The concepts of the minimum, minimum principles and total occlusion refer to evaluating the occlusion as a whole. Therefore, at one time, I referred to my occlusal theory as total occlusion. Even now, if someone asks about my approach to occlusion, I respond accordingly. We can perform canine guidance, anterior guidance, group function, bilateral or unilateral balanced occlusion, and fully balanced occlusion. We cover everything, including malocclusion. Therefore, we cannot claim to use a specific type of occlusion. Where others distinguish lateral guidance and discuss their own occlusion, we simply use total occlusion, literally. We believe that explaining it in this manner is most appropriate. So in conclusion, the purpose of explaining this with game theories such as the minimax principle is to provide insight into the diagnosis and treatment of occlusion, not a solution. There are various solutions. As I mentioned earlier, you can achieve greater or lesser contact than with natural teeth. You can place many implants or use larger fixture sizes. There are various approaches. While it's essential to accurately diagnose and analyze the patient's occlusion, determining tactical objectives is important. Once strategic goals are set, you need to decide on tactical solutions. We discussed all square in eccentric occlusion and sequential guidance in eccentric occlusion. If these are not properly aligned, it can ultimately lead to traumatic occlusion, prematurity, and various other adverse outcomes. Today marks the conclusion of our extensive implant occlusion lecture. Of course, I provided thorough explanations, but some of you might still find it challenging to understand. In fact, many of you are hearing this information for the first time. I apologize if I did not make it sufficiently clear, and I will continue to study diligently to explain these concepts more simply in the future. Thank you for your hard work thus far. Next time I intend to present lectures on a new theme, although it is not yet certain. I am considering explaining specific aspects, such as the posture for implant placement. Thank you for your efforts.